with our friend Farrell League, and I'm pleased to have many of our colleagues: David Kettles, Ahmed Subhi, Ahmed Jailan, Qais Bakir, and Robert Myongi. So welcome, Ahmed Jailan. The floor is yours.
Thanks very much, and it's really exciting to be part of this session, a session which is going to be looking at paravalvular leak with a live transmission from one of our Africa PCR directors, Farrell and team will be demonstrating how to do this. The purpose of this particular session is to go through the indications for this, to have a discussion around what the common how common a frequent a problem it is, whether it's a space that requires a very focused group or whether it's something that any interventional cardiologist can do. And then now to look at the step-by-step process for delivering the whatever closure device you want to close the paravalvular leak with. So without further ado, hand over back to Habib Gamra to introduce the team on the ground.
Okay. Thank you, Mohammed. I just would like to ask Farrell to present the case. I think it was supposed initially, as we discussed it as a scientific committee, to have a live transmission, but you realize it's not easy to have a live transmission on paravalvular leak. And then we decide with Farrell to have rather a recorded case that is full of teaching lessons, and we look forward to it. Farrell?
Thank you, Habib, and I see you've got a great meeting on the go here, and congratulations for that. You've got a wonderful, broad faculty from all over the world. I'm very impressed so far. So I would love to have done a live case for you guys. It was really my intention, and we've traditionally done live cases for this meeting, but during this second wave of COVID at the moment, we've currently restricted on elective cases. So we were not able to do a live transmission. So I'm going to show you a case that we actually did for one of the Africa PCR Congresses, a paravalvular leak case that was live. I've edited the video, but I've kept the original commentary from the room and the auditorium. So I would have, if we're going to take further comments, I'd have to pause because then we'll be talking over existing voice. So you'll have to just indicate by show of hands if you need me to stop or raise your hand. So let me present to you the case now first. Okay, so I'll first show you the slides of the patient presentation. So this is a case where surgery is no longer an option, a patient with mitral valve paravalvular leak.
Ouais, carré, tu vas bien? Ouais, c'est bon? Ouais, carrément.
So the patient is a 47-year-old male who had rheumatic fever in childhood, and in April 1992 had infective endocarditis with severe mitral regurgitation and had a 31 millimeter St. Jude mitral prosthesis implanted surgically. And then a year later, due to poor warfarin compliance, which is a common problem that we have in young patients who get prosthetic valves in Africa, he presented with stuck leaflets and valve dehiscence, and because of his poor warfarin compliance, was given a mitral bioprosthesis, a 29 millimeter Sorin valve. And this was complicated, the surgery was complicated by CVA and apical MI, which was embolic. But as expected, this valve only lasted 10 years. And in 2003, he presented with heart failure and mitral stenosis, moderate mitral regurgitation, and had redo metallic mitral valve with a 27 millimeter Myra valve. So he's had 3 previous stenotomies, and the last surgery was reported as very difficult with many adhesions and lots of bleeding. So in 2017, he presented with a 3-month history of a decline in effort tolerance, developed heart failure due to severe mitral regurgitation and hemolysis as a result of a paravalvular leak with intractable class 3 to 4 heart failure. Infective endocarditis was excluded, and he had recurrent admissions for transfusion and intravenous diuresis and had a very poor quality of life. And fourth redo mitral valve surgery was declined. So I think we can all agree that a fourth surgery after two last surgeries were very complicated with some complications of the second surgery, including stroke. He was very high risk for a fourth operation. So this is the echo which demonstrates a severe paraseptal. I just want to change my view so I can get better visualization of my screen. The severe paraseptal medial paravalvular leak from 2 to 6 o'clock, measuring 2 by 4 millimeters. You can see on this moving image the extreme mitral regurgitation, and you'll see more images later. So what I'm going to show you is a live case demonstration which was done at Groote Schuur Hospital in Cape Town. I operated on this case for the Congress with Ralph Berkemeyer and Shaheen Pandey, and Farouk Mamdou was on the echo. I can take any questions before we go live now if you want, because the recording's about 27 minutes. If you want me, otherwise I can go ahead.
Sorry, you have to make 3D echo and 2D echo, or transesophageal and 3D. What are the most appropriate are you going to use even to help you during the procedure?
Yeah, we're going to show you all of that in the live transmission. We will show you 2D and 3D echo, which will give you all the detail on the leak itself. So I have Ralph with me and Farouk. We are going to introduce the rest of the team in due course. Shaheen will be also assisting on the other side. So if you can show the echo images, please, for Farouk to show you what we've done in the lab to confirm the findings.
So we can look at the mitral annular ring over here. Those are you can see it's a bileaflet prosthesis, and these are the hinge points that we described earlier. And if you get an indication that there's a defect in the tissue over here, and that's the paravalvular leak we're looking at. You can rotate this image around. You can appreciate truly that it is a circumferential defect, and it extends right around the circumference of the ring, almost more than 25% of the circumference. And there's almost a rocking motion that's appreciable here. Is we use the X-plane to identify the plane of the leak, as you can see over here, with the Cine plane adjusted. We can see there's a very large defect coming through, and we attempt to look at that with 3D color, which you can see over here. We have to slice out a lot of the image to appreciate the whole valve. We don't want to see the rest of the valve because our frame rate really drops. So what one wants to do is just identify the site of the leak. Looking at it again, zoomed up in 3D, I can tilt the image for you. We can appreciate that it's hugging the septum, the interatrial septum, making the defect very difficult to approach it, I would say, from a transeptal perspective, which one would have to consider deploying more than one device.
We've already done a transeptal puncture, and then we have got a sheath now in the left upper pulmonary vein. And we've looked at the coronaries to look at the coronary circulation around the apex. So if you can show the coronary images, please. You can see that in this LAO projection, the actual apex is free of coronary arteries. And the right coronary, or we can show you as well, does not cover the apex. So we're planning to do an ultrasound guided puncture of the apex and place a sheath and cross retrograde, which I'm going to do now. If you can look at the camera, we've sheathed the transthoracic probe with some gel in it and some elastic in a sterile sheath. And we've already marked the apical position in this patient's current posture. So the way he's lying, we've marked where to go. And now we are going to see which angle we need to use to puncture the left ventricular apex.
We can see that goes well.
A little bit more gain and be able to see the needle. So I can see the angle of the puncture, exactly where I need to go. So if you can see the echo, I can see the apex. So I'm going to follow exactly this line and try and keep some echo visualization. And there you see the puncture. So I've got a wire in the ventricle. Okay, there we go. So once the sheath goes in, I'm just going to advance the remainder on its own over the dilator. Then take out the dilator with the wire in, make sure we've got blood flow back. There we go. And then flush. Okay, so now we can remove the wire, the sheath in the ventricle.
Can we switch to?
And I'm going to come back around the other side and ask Shaheen to come here. Now we're going to be crossing now retrograde, and then we will close antegrade with an exterior rail to offer us directional support. And I think that this technique's particularly important. Give me the AL1, please. This technique's particularly important when you have a paraseptal leak in this medial position like we have, where it's very difficult to achieve adequate angulation and forward push of your catheters. So if we have this scenario with exteriorized wire, we can stiffen the whole system and create the appropriate direction. Just give it a few more tries.
That's quite posterior. That's better.
Yeah.
Yeah.
Could be
Yeah.
That's better. Yeah.
That looks better.
That looks better. It's not through the aortic valve for sure.
Actually outside of the surgical valve, right? Going towards the atrium.
Okay, so what I want to do now is to get into the pulmonary vein. So I'll just ask Farouk if I'm in the pulmonary vein.
Yeah, I'll go there now. That's fine.
Have you heparinized the patient, Cheryl, and how much heparin?
Yeah, so we're keeping the ACT about 300. We actually gave heparin 258 right now. So I think we can give another 3,000 heparin. So I think we're in the pulmonary vein now.
Yeah.
So we've got now the sheath as well in the pulmonary vein. And we are going to snare a Terumo wire and pull the whole system through the transeptal sheath.
Yeah, okay.
So Ralph's going to load the snare into into its own catheter. And I'm going to put the catheter into the transeptal sheath. Okay, so I'll ask Ralph to push out the snare. Push it out. We just try and turn this catheter to point up towards the other. Yeah, so it's going to be a bit tricky to pull this back too much, but let's see. Let's take the Terumo.
So Rob, just maybe explain to us what you're trying to do.
Yeah.
You're opening the snare and they're going to come back with a wire and
Yeah.
across the snare with a wire.
That's the idea, just to push the wire through the snare now when we come back with the catheter, but we have to pay attention that not everything is falling out, as we don't have a lot of support.
So I'm going to put the wire in first and then pull the catheter back and then slowly pull the wire back. So show me the tip of the catheter, please. The one in the vein.
Yeah.
So there's the Terumo wire. I'm going to pull back I'll pull it, keeping the wire in to come close to the snare. So this is the danger. I need a torque on this wire, please. To see? Yeah, we've got it. So I'm going to ask Ralph to pull that wire in, and then we're going to hold it tight, Ralph. And then we're going to pull back this catheter to straighten everything. Pull, Ralph.
I pull.
And then we try and get this. Yeah, there we go. So we've gone into the whole system. So I'll ask Shaheen to push this all forward. Pull.
So you're trying to now pull the wire and you're always also pulling the antex left catheter.
Yes.
Yeah.
Sterilize the catheter.
Yes.
Yeah.
The
So
red-
if you can show
Pay
here,
attention,
we
pay
wait
attention.
until
Stop. Don't push.
Just be careful, you're going to run loose in here.
Are you tight, Ralph?
Oh, I still have it.
we've got the wire. So if you just hold the wire tight, we'll straighten everything. Pull tight on the wire. Okay, now you can push the catheter while we hold the wire. We've got the wire out.
Just hold it forward a little bit so it looks nearer, and then you can take it off.
Screen. Yeah, now you can see the angulation much better.
So now we're pushing the
Whoa, slowly.
So she pushing the catheter via the apical function.
Yeah. Yeah, the catheter's out, you can see here.
Yeah.
If you get some light here for us. So you've got the catheter out the transeptal sheath.
Off the table.
So now I'm going to pull I'm going to ask, so we've now got a catheter outside the body on both sides through the patient. So I'll just ask Shaheen to pull the wire right out. And then I want to implant super stiff wire, please. So I'm going to give the super stiff from this end to Shaheen. And this would start, it's just easier to push out the catheter this way. And then I'm going to be working from this end. So I don't want to be keeping working on the floppy end. So I'll ask Shaheen to just hold the catheter tight, screen. So you see things are starting to straighten now. Have you got the wire? So I'll ask Shaheen to pull the wire. Pull, pull, pull. Pull just slowly. More. A little bit more. Okay, now we've got a wire across screen. Let's just check what it looks like. Okay, so then I'm going to tell Shaheen, I'm going to hold the wire and tell Shaheen to pull the catheter out. So I've got the wire, it can't come out. Just pull the catheter. Well, slowly, Shaheen.
Slow.
Slowly, slowly. So you see everything's straight.
Yeah.
So everything's looking much more coaxial now.
Looks good.
Come pull it right out, just pull. And then we will take a guiding catheter from Shaheen's end. Give us the guide, and the guiding catheter can accommodate 2 wires. So we're Shaheen's gonna push the guide in. Screen, please. We need to make sure the guide goes into the sheath. So you often need to rotate a bit. There it goes. Okay, just go slowly because we don't want everything to come. You want to get wire. Okay, it's got wire. So you can pull a bit more wire. Okay, so now we've got this guide catheter out, you can see here. And I'm going to take a V18 wire and put it through the guide. So we've got a second wire as a safety wire. Sorry. Just sometimes tricky to get it in.
So after that, we will have a 35,000 inch wire in and an 18,000 inch wire back.
Okay, so now I'll get this will come out the back. And we take that all the way out.
So why are you putting 2 wires across?
So the reason we want 2 wires is so that we can first of all have the ability to start again if everything is not suitable. We will have a wire in so we don't have to recross the defects. The second thing is that we want to try and put 2 devices at the same time. I'm actually, as we're working, thinking it may not be possible because of this extreme angulation. So I'm going to ask Shaheen to pull out the catheter again. Now that we've got the 2 wires. Now this device, Farouk, am I correct, measures about 25 in length and about 5 millimeters in width.
That's correct, yeah. We got just under 25 and about 4.5 in width.
So we are going to use the Occlutech devices because I think that they are ideally suited for this kind of scenario. The sizing is quite tricky because we know we're not going to manage with 1 device. And I think the size is actually, we're not sure about which size to use, but we think that 2 12x5 devices will be correct. I'm going to now take out the transeptal sheath. We're going to leave the safety wire and the other wire across the apical sheath, and we're going to place the delivery sheath parallel to the V18 wire.
You could use the 3.
So the V18 wire is not going to be in the sheath at the
to
femoral venous access site, but the V18 wire will still remain through the apical sheath. So I'm going to now remove the transeptal sheath. I'm going to ask Shaheen to hold the wires.
Both.
And then we will take the delivery sheath over the super stiff. And when we get to the ventricle, I'm going to ask Shaheen to remove the apical sheath a little to retract it. Here you see us coming up through the septum towards the valve, and I ask Shaheen to retract a little and to stiffen the wire. It's actually quite difficult to cross, I have to say.
So you're having a challenge crossing with the sheath?
I am. I'm asking Shaheen to pull on the wire. Pull the sheet back a little more.
I just cut it out a bit.
Sure, it's not crossing, I must say. So we might have to rethink our strategy. That's non-French. Let's just see. I can't cross.
If you're having trouble crossing, does that have some implications for whether the device is going to impact on the mitral valve itself?
Yes, it may be a relevant factor. So we've got so much of a rail here. I must say I wouldn't have anticipated difficulty crossing. You can see the difficulty. I can feel the whole system rocking like crazy. So I don't think that I think we're going to have to change strategies and go with smaller sheaths. See, even the dilator doesn't go. Cool. We've got such a yeah, there we go. But not the sheath. We're also likely to impact the mechanism here. And it's going to be very difficult to control everything. Sheath back a bit. Yeah. Okay. We're across now. So the question is, do we try and put in a vascular plug and get a partial closure? So once our left ventricular disc is across and we're not happy, we will not be able to push anything forward. So it's going to be a one shot. So this is the moment where you have to pull the wire, I'm afraid. We're going to have to go with the AVP3. The discs are smaller, so it may be advantageous in this case because of the difficulty with the proximity to the valve edge.
No, we don't need it. Huh?
Okay, you want to run this? Run? Acquire? Okay, that's both discs. So we got, yeah. Okay, right. So now. Yeah. Yeah. So. Yeah, we go. My problem here is I cannot move the sheath. It is so tight in the defect that I cannot rotate it. It's frozen. I can barely pull it back, to be honest. So, in fact, pulling back the sheath, it's struggling to come. So I think let's get into that RAO view, please. Oh, we are in it. Okay, screen. So I don't really have much control over the device, to be honest. But I think, do you agree we're in the right position in terms of what we've released distally? It looks like the valve function's okay. So I think we're going to have to release it in this position. I can't pull much more on it. What do you think, Ralph?
Yes, we'll do that.
Okay, so we're going to release the atrial disc.
There we go. Can everyone see that?
Save that. Save Flora, store, stop.
Yeah, leaflets are moving nicely. We can see the device.
Can you see the other side of the
It's torch not in the middle.
Not too well.
Sort of channel,
Yeah.
not torch in the middle.
Atrial side looks fine, and on the LV side, yeah, you can see too. That looks fine as well. It is much better.
I must say the MR is much less.
And the patient's blood pressure, hemodynamics there.
Perfect. There is still a leak, but it's considerably less. So we can try and put another device on the other side. There is actually just one more leak, and that may be worth persisting because we've made good progress. And I think if we could put another AVP in, we would succeed in closing this completely.
If you look at the size of the device, the discs, it's almost it's about 60% of that. I'll try and measure it.
Didn't track. So let's just, it really helps to have the occluder there to aim for. It's trying to cross. Okay, we're across again.
Across.
In the right place.
Yeah.
Just get the wire deeper. In some small. Okay, we're across with the sheet.
There you go. Yeah.
The sheet's across now. So, and then we'll leave this cable attached, and then we'll release them simultaneously afterwards. I'll go parallel to this cable. Okay, we're probably in the LAA there. So we'll just carefully pull out and leave the wire there. We may, I don't want to embolize anything. That's the last thing I want to do. Okay. Are we in the LAA or in the vein?
Oh.
It's just fluoroscopically before
Try now.
to the structure.
Cool. Yeah, we got it. Cool. You've got it tight. You've got it tight.
Yeah, I hold it tight. Turn and I can start to pull.
Yeah. Just turn this. Just pull. Yeah.
Just start pulling.
Yeah.
That's great.
Okay. Without this dislodging the other device. Pull the sheet back a bit. Now it looks like pull the sheet. Looks like it's going to go. No, got to pull. Yeah. Okay. Okay, you can fluoro this. Okay. Right. Ready to pull back?
Okay.
Just have to watch the other device.
And this one's right near the disc hinge point, so we'll watch the valve disc as well.
Screen. Huge amount of resistance to retraction of this. Just going slowly. How's the discs? Okay.
Discs are moving well.
I feel a little.
Very close to the disc.
Yeah.
Yeah, looks good.
Have to pull it a little more. I'm leaning on it a little more. I think that's better.
Yes.
So let's just see how we're looking on the ventricular side. This will confirm I'm in the right place.
Discs are moving well. Yeah.
You happy to unsheath it, Rob? I don't think I can pull it back in more because I'm worried of pulling it out.
Okay.
Same like in the other one.
Very good. The second device is just interdigitated on top of the other one. And you can see the threaded insert type of they're pointing in slightly different directions, which is good actually, because it means we're not, if you look at the way the threaded insert is pointing the second device, it's sort of almost perpendicular to the discs, the hinge point, which means we can't be impacting. Can everyone see my screen?
Can we run LA pressure, please?
There's the second disc over there. And if you look just sort of underneath,
I think I don't see any MR actually.
just this little piece over
Virtually
here.
nothing.
Virtually little tiny smidge. Right. And we see good motion of the leaflets as well.
Farouk, you happy with the leaflets? We can
Yeah.
remove everything.
Leaflets are moving extremely very well.
So we're going to pull the one. Okay. And we're releasing the other one. Yeah, there we go. Okay, so they're both released. How's it looking, Farouk?
There's a very little MR, a little puff.
There's
The
virtually no
leaflets,
MR. So I
virtually
think
no
we can be
MR right
delighted
now.
with the result, to be honest. I'm going to take a 6 French angiostil and a coronary wire next to it as a safety wire in case we have a problem. It's interesting to see the movement of the sheath, if you want to focus on that, in the ventricle. Okay, if I go through the valve, I don't mind. I think I'm through the valve. Now give me the coronary wire. Yeah, so in case there's a problem, we can get the sheath back in to tamponade. So we put a coronary wire in. So I'll leave the coronary wire adjacent. Okay, so we're going to pull out the sheath. Screen. Okay.
Can we have the lights on?
Lights, please. So I'll put
Six French or 8 French?
6 French. 6. So I've got flow back. Right.
I thought the MR got worse, but it was your wire through the valve.
Okay, now we're okay, so I'm going to ask Farouk, we're closed now. I'm going to ask Farouk to check that everything looks okay.
Pericardium looks good.
There's the coronary wire you see next to it. So I think I'm going to pull the coronary wire if you're happy.
Yeah, happy.
Okay, so I'll just pull that. And then I'll just tighten up the angiostil once more. And then we just cut. There's no bleeding if you look at the site. You can raise the panel, raise the panel. So you can see at the site there's no bleeding.
And there's no effusion.
And there's no effusion. Okay, so I'm going to cut the angiostil wire, the angiostil cord.
There's a little bit of an interatrial septal defect.
Okay. Okay. See the ventriculogram and beforehand, and you can see the degree of MR, which I think is pretty dramatic. You can see the entire atrium. There's just a little puff of MR. It's quite okay. So I'm going to ask Shaheen to close up here, and I'm coming over to the room. Thank you very much to everybody. Thanks, Rob, for your support. Thanks to the team. Thank you. Okay, so just to show the patient came to the auditorium the next day. And he was discharged at 48 hours. So I'm happy to take any questions.
For an excellent case, yeah. Why do you do the apical and transeptal? Why don't do only transeptal? You can do the wiring for the paravalvular leak, and then rather than to make it with a steering and then go both ways. Did you try it before?
So we don't always do an apical stick. The reason for the apical stick in this case was that the leak was paraseptal, and so the angulation was very unfavorable. It was right along the interatrial system, and it was very angulated towards, you could see the angle of the devices. So it would have been very, very difficult to cross with the sheath. As you can see, with the sheath was so difficult to cross. You could perhaps do it from the ventricular side, but you're limited to 6-French sheaths unless you're willing to make a bigger defect in the ventricle. So that is the reason for going to give the support from the apical sheath in this particular case. But this, I'm showing you this because it is not the average approach. We do this on occasion.
Errol, just on that point, there is an evolution in the procedure, isn't there, over the years? I mean, I've seen some of the cases now no longer being done with a continuous AV loop, not necessarily requiring a rail to work on, but sometimes putting a super stiff wire into the LV and working like that with that wire halfway down the aorta. Do you continuously aim for an AV rail, or do you sometimes just use a super stiff wire and you get enough support, depending on your puncture site and the defect site, obviously?
A lot depends on the size of the defect and the crossability. These defects can sometimes be very serpiginous and extremely difficult to cross, as you could see in this case. The sheath really struggled. Without a rail, there was no chance of crossing this defect. Those were 4 French catheters going retrograde from the ventricle, so those would cross. But even 6 French catheters would not cross from the ventricular side, which I didn't show you those details. But really, you could only get a 4 French catheter across this defect. They were so difficult.
Yeah, I mean, I would congratulate you and Ralph, and your editing made this look a very, very simple procedure, but it's an absolutely brilliant result. I'd really congratulate you on that. I know it was a time ago. I've watched this for the second time today, so congratulations. But just another question. It's an interesting pathophysiology, isn't it? I mean, we know 2 to 15% of mitral valves eventually end up with paravalvular leaks. Now, some of them, like this one and like the one that you closed for me the other day, are many years after mitral valve implantation. Are there any thoughts about the pathophysiology? Is this late fibrosis? How many of them are endocarditis related? Do you always screen carefully for endocarditis in these patients? I think just for our audience, I mean, what is the pathology? This is clearly not, in this particular case, a surgical problem that the valve wasn't, implanted correctly at the beginning or securely at the beginning, because this is 10 years, I think it was, after 14 years after the redo. You're getting a horrendous crescentic leak like this. Can you comment on the pathophysiology?
Yeah, so it could be healed endocarditis that we see. There may have been endocarditis, but I think it is difficult to understand sometimes. We don't have evidence of endocarditis. I welcome other comments. Maybe I see Horst Sievert's on. Maybe he's got some comments on the potential cause of this, but we often don't know why they present so late. It may be that they had a leak that wasn't too bad and weren't clinically relevant, and then it progresses just a little bit to give enough problems.
We have seen both. We have seen cases who started with a small leak, which didn't need any treatment. Then they got endocarditis, and then the leak increased. But I think there are also many just have not been diagnosed before. I think it's a mixture.
Thank you, Professor Fire, for this very nice case. Unusual case. We've never seen this before in Tunisia, but we are doing some paravalvular leak in the Rugby Hospital, but only with the anti-arterial access. So my question will be about the ventricular puncture. How do you lead with, how do you treat the ventricular puncture after retrieving the wire before? I know that there is an adherence of this in this operated patient, but sometimes if you have pericardial effusion, how do you do to close the puncture site?
Okay, so you saw we used a 6 French angioseal. What I always do is have a supportive coronary wire parallel to the angioseal, so there remains a wire in the ventricle. And if there is a pericardial effusion, you can go back with a sheath and put another angioseal or even another vascular plug. You can put a vascular plug too, or other device to close the defect if it's unsuccessful. But But the only time we've had problems is if you miss the apex. If you don't get the apex, that's when you can have potential problems. Every time we've hit the apex, there's not been an issue. Of course, one day I think we will hit a coronary. We haven't had that. So that is the main concern. If you hit a coronary, you have to be ready to treat that as well. So I don't think this is an approach to be taken lightly, but it is necessary in one or two cases. You could create an AV loop and try and use that and snare wire in the aorta as another method of support, but it changes the angulation. In this case, to have a nice straight shot at the apex was the only way we could successfully cross this defect with the sheath.
Thank you very much, Farrell. I think that was a fascinating case. I'm sure there are many, many other questions, but we have to move with the program. And it's my pleasure to introduce Horst Sievert now. We would like to switch the talks. Horst is maybe has other commitments anyway. So we'll start by the talk of Horst on how to close paravalvular leak. Horst? Horst, you're on mute. You have to unmute yourself.
Can you hear me now?
Yes.
Yeah. Sorry, I have to go back. Okay. So thank you very much, and thanks to the organizers for inviting me. So this is a talk with 15 tips and tricks for paravalvular closure. Hopefully I will make this in 10 minutes as you asked me to do. So this is tip number one is regarding vascular access. What is the best access for paravalvular closure? Well, femoral access, in my opinion, is strictly preferred. Radial or brachial access, we use this only occasionally because in some X-ray projections, it's very difficult to bring the C-arm in the proper position if you do this from the arm. Then transeptal access is rarely needed for para-aortic leaks, although we had some cases like that. Also for mitral, transeptal access is not my primary approach anymore. I try to do the mitral leaks also from the aortic approach, from the transfemoral arterial approach. Transapical is usually only if other techniques fail. At least that is our strategy. And we do this, if we do it transapical, we do it percutaneously, or in very rare cases with mini thoracotomy. So tip number two is the angiography for aortic leaks. I mean, we do this under echo guidance, but we also would like to have angio during the procedure. So we locate the defect in TEE, and then we adjust the image intensifier accordingly. So in this case here, when you look from below, you have 30 degree, it looks like Ario but this patient is, the TE is coming from the back side. So that means in this particular case here, you should go 30 degree LAO. And then we do a selective angiogram. In aortic leaks, we use a pigtail or multipurpose or FR4 or the sheath. And in mitral leaks, we do the angiogram via sheath after crossing with a wire. In this case, as I mentioned earlier, we would go to a 30 degree LAO projection. So we do the angiogram with the image intensifier adjusted according to the TE images, and the defect diameter and the distance to the valve can be measured angiographically in most cases very well. How to close the defect? Well, we measure the defect diameter in TE and angiogram. We cross the defect, hydrophilic guide wire, diagnostic catheter. In aortic leaks, we do it retrograde via the femoral artery. In the mitral leaks, also retrograde via the femoral artery, and then to the LV, and then through the leak into the left atrium. And only if that fails, then we do transeptal puncture for closure of mitral leaks. This shows you a case of a retrograde mitral leak closure. So in this case here, you see a transeptal catheter was there, but we didn't use it in this case here. You can see the device deployed, and this is after deployment. This is an AVP3 is an oval-shaped device for paravalvular leak closure. Tip number three, be prepared to overcome friction, and you have shown this in your live case very well. You should prepare yourself to overcome friction when you introduce the catheter or the sheath into the leak. And you can use wires of different stiffness. Sometimes you need a softer wire. Sometimes you need a stiffer wire to bring the catheter or the sheath across. Hydrophilic catheters help. Hydrophilic sheaths help. And then if that all fails, you can do it balloon assisted, and we'll show you what I mean. Then transapical or transeptal access and snare and pull, creating an arteriovenous loop. And you could also consider, and this is also something you discussed in the live case, consider two smaller sheaths side by side. I will just explain what I mean with balloon assisted. So in this case, we were able to insert a Swan-Ganz catheter into the left atrium, but no sheath and no catheter. So then we advanced the sheath into the left atrium, coming from the aorta and the left ventricle, by pulling and pushing at the same time. So the balloon is inflated on the LA side, and then we pull and push, and this brings the sheath across. Just to give you better understanding what this means. So the wire is across, the sheath or catheter does not go across. It's not because the leak is too small, it's just because of the interaction with the valve or with the calcium in that area. And then if you are able to bring in a balloon, for example, a Swan-Ganz, or could also be a PTA balloon or PCI balloon, then you inflate it, then you pull the balloon back into the hole, and this centers the sheath or catheter, and then you can advance the catheter or sheath by pulling and pushing at the same time. So you pull on the balloon and you push on the catheter. Tip number 4, this is an example, paravalvular closure post-core valve. It's very important if you have that situation that you cross the frame at a very high level. If you cross right here, then it would be a lot of friction to get the sheath in. But if you cross high up, then you can easily cross the frame and have no friction there, and then you can cross the leak thereafter. Tip number 5, be prepared to overcome friction when you pull back the sheath out of the leak. And that is frequently an issue in leaks after TAVI. So if you have the sheath across, you want to deploy the device, and then you encounter friction which you did not encounter when you advance the sheath through the leak. And then you have to really pull very gently and with a heartbeat, and then sometimes millimeter by millimeter, the sheath or catheter comes back into the position where you can finally deploy the device. Then observe and record valve leaflet motion. That is, of course, important in the mechanical valves. You should do this under fluoro and or TEE, and show you an example here. This is the motion of the valves, and you have to adjust the image intensifier so that you can really see the leaflets when they open and close. Then when it comes to device selection, these are the devices which can be used for mitral paravalvular leak, and you can see those devices which we frequently use, that is AVP2, AVP3, and AVP4, but we have used all the other devices as well. There are dedicated devices like the Occlutech paravalvular leak closure device, 2 types of devices, square and rectangular, and both versions come with a narrow and with a thick waist, so narrow waist and thick waist. As we have various options to choose from when you use this device for paravalvular leak closure. So then considerations for device selection. So tip number 7 is the waist of the device or devices should be 2 to 4 millimeter larger than the leak. And then if you have an oval-shaped or crescentic leak, you should not oversize round devices. So because when you oversize a round device, it will not adjust to the anatomy of an oval-shaped leak. It will just be compressed, but it will not take the shape of an oval-shaped leak. And if you have an oval-shaped or crescented leak, you should use an oval-shaped device like the AVP3 or the Occlutech device, or you should 2 or 3 or more round devices side by side. Tip number 9 is measure the distance to the valve ring and then use the largest device which fits in without blocking the valve leaflets. And if you have a small distance, you should use a device with small ring. And that is important because sometimes by echo and also by angiography, it's really hard to measure the diameter of the leak. And if that is the case, then just pick the largest devices which fits in the groove of the mitral valve annulus, for example, without interacting with the leaflets of the mitral valve. Tip number 10, length of the leak. If you have a very long leak, and sometimes these leaks are really like long tunnels, then you should prefer a long device versus, obviously, in shorter leaks, you can use a shorter device. You should think about the hemodynamics and the risk of device embolization. So in mitral valves, there's no gradient across the valve during diastole. There is a gradient during systole, and the pressure obviously is higher in the left ventricle than the left atrium. So in mitral position, the embolization into the left atrium is more likely than the embolization into the other direction. And that is important when it comes to the question where the device exactly should be placed. And then in the aortic position, there's no gradient during systole. There is a gradient during diastole, and obviously the pressure in the aorta is higher than the left ventricle. So in this case, embolization into the left ventricle is much more likely. And again, this helps you to guide you where to position the device in a case where you could place it either more towards the aorta or more towards the left ventricle. Tip number 12, never newer devices without fabric, like the AVP2, for example, but very fine wire mesh, they occlude faster and cause less hemolysis. And in the past, we have used very often the PDA occluder, PDA1, or the muscular VSD occluder. They have not this fine fabric, and therefore in these devices, you see much more hemolysis compared with the newer devices. There's one exception, the AVP4 needs much more time to occlude, and sometimes they do not occlude at all. So I use this only in very special situations. Tip number 13, very often it is difficult to introduce a sheath into the leak due to friction, and devices which need small sheaths are preferable. And this is the situation where I would use the AVP4 because this goes through a 4 French diagnostic catheter. And I've used this device, especially the AVP4, especially in leaks after TAVI. And again, tip number 14 is related to paravalvular leaks after TAVI. There are irregular leaks between the frame and the native calf leaflet. So it's a different situation than in surgery, where you have on one side the artificial or biological valve, which is a smooth structure, whereas here we have the native leaflets in the way, and they can often be crossed only with very small catheters. Again, this could be an indication for the AVP4. Then device implantation, of course, we have seen this during the live case. Then you do a tug and push test to make sure that it does not embolize. And finally, the device is released. And then tip number 15, before you release the device, you really should be sure that there is no interaction between the devices and the leaflets, so they should move freely in all directions. And do not forget to check again valve leaflet motions after you have released the device. So 15 tips and tricks in 15 minutes. Thank you very much for your attention.
Horace, thank you very much for this nice lecture. So the aim of this is to estimate the size and the shape of the defect. Is it sometimes it's difficult to cross cases, and sometimes you need more device? I mean, 2 devices in one patient, like the mitral clip, for example, just not sufficient, or in every case you succeed to cross and you put the device, the actual device?
No, very often it happens that I have to change, that I start with just one sheath and I realize that the device does not close it. Then I try to push the sheath again across the leak, and then I insert a second device side by side, a second sheath side by side. And sometimes we need 3 or even 4 devices side by side. And in general, it's better to use, it sounds more complicated, but usually the results are better when you use more devices than just one. So try to use 2 or 3 devices whenever possible, because the results are better. Smaller devices, but more devices.
All right. Thank you, Horst, very much. Just, we're running out of time, but I would like to ask a question to you and to Farrell. When do you think this cannot be eligible case for percutaneous closure? is there any anatomic features that would tell you that actually this is not going to go and it's not a good indication?
I think a contraindication, of course, if there's endocarditis, but when it comes to morphology, I think those valves which are really rocking, where you see the valve is not really engaged anymore on the native annulus and the valve is moving, then it's too late. Then surgery is required.
All right. Thank you very much, Horst. Now it's the turn of Jonathan Byrne to tell us how he would manage patients with a paravalvular leak. John, welcome.
Thank you, Habib. I hope you can hear me. Apologies for coming late to this session. I'm afraid I had a malfunction with my timing, so deep apologies. The only caveat is I do know Farrell's case because I saw it presented live, so I know how difficult that was. And thank you very much for inviting me to talk at the meeting. It's always a great pleasure. It's a shame we can't be together face to face. Now, my job here is not to talk you through paravalvular leak closure. I wouldn't dream of coming after Horst to suggest that, who's far more experienced than I am. But what I am going to talk about is something you touched on briefly just then, is which patients should, and perhaps more importantly, which patients shouldn't have paravalvular leak closure. It's about patient selection. And I'm going to sort of whiz through a little bit of the background. So this won't be technical, I hope. This won't be procedural. This will be about patient selection. So it's important to recognize that paravalvular leaks are common. So they occur in about up to 10% of surgical aortic valve replacements, up to 15-70% of mitral valve replacements. And they've also been seen with decreasing incidence in the post-TAVI population. But most of these do not require intervention, and really only 5 to 10% in total would need treatment. And we'll talk about the indications in a moment. So I think it's important to make sure you select the patients correctly for the procedure. The other thing to say about PVL rates is that they increase over time. So immediate PVL rates are low, 1% in the aortic position, slightly higher in the mitral. But at 11 years, that's degenerated significantly, particularly with mechanical mitral valves, which at 11 years have a PVR rate which approaches 20%. And the reasons for that are complex. Some of that is patient-related, but some of that is also valve and suture-related. It's less common in the tissue valves, but of course, they don't last as long anyway. So again, I think it's important to recognize that in following patients up, you may see an increase over time. It's important to keep these patients under fairly close surveillance. Now, in terms of indication for closure, I think we should also talk about the absolute indications for closure, because this is the most important. So I think the only primary indications for closure are symptoms of heart failure or signs of left ventricular dysfunction, so progressive left ventricular dilatation with either aortic or mitral leaks, heart failure symptoms not controlled by medical therapy or even partly controlled, and perhaps the biggest bugbear of all is hemolysis, particularly with valves in the mitral position, which can be very difficult to treat. I think the relative indications you see to the side, reducing risk of endocarditis, asymptomatic, mild leaks, are not really relevant to interventional practice. I would shy away from those and stick with the very hard indications. The third thing to say is what about the other options? In this population, surgery is not a good option. So I think as we've got more and more experience with percutaneous closure, it's very, very rare that we would send a patient for surgical repair of a leak unless we have adverse features, which I'll come to in a moment. But you know, the rates of mortality associated with redo surgery are pretty high. It's well over 10% with a single time redo and more than 20% with more than one operation. And those patients with mitral leaks have a worse outcome than those with aortic paravalvular leaks if they undergo surgery. And I think this should be, in my view, a last resort for this patient population, particularly if there's a good interventional option. And how good are we at percutaneous closure? Well, again, not everybody does it, and the number of institutions that do it are quite small in high volume. This was a study from the UK and Ireland from about 4 years ago that Paddy Calvert put together, which was only, if you look, 240 procedures in 20 institutions, quite small numbers over 10 years. The primary indication for closure hemolysis, and that's associated with a 3.9% hospital mortality and a generally good reduction in site-reported resolution of regurgitation. So, from a 61% start of severe leaks down to about 41% with mild, and a proportion with residual moderate or severe. So again, we're not bad. I think that this is also reflective of relatively early practice. So this, 2005 to 2015, I think in the past 5 years, I suspect that we've got even more experience. So I think it's worth remembering that it's not perfect, not a perfect procedure. And this is my strategy for selecting patients for either aortic or mitral valve PVL closure. We touched on it briefly before, but if you find a significant leak, the first thing to do is properly assess that. And that's not an easy feat, particularly in patients with multiple leaks around the mitral valve or aortic valve, or with two prostheses where the shielding makes assessment of the leak very difficult. But you can use obviously the density, the CW signal, the deceleration velocity with AR, etc. And in the mitral valve, look at systolic flow conversion and the PISA. But these are sometimes pretty difficult to see, and often you're left with the correlates of regurgitation to guide you on whether the leak should be closed. That is there left ventricular dilatation? Does the patient have symptoms? I think if the patient has symptomatic hemolytic anemia, I think there's every reason to go on and think about paravalvular leak closure. I think if the patient's asymptomatic with left ventricular dilatation, it's worth attempting closure, but it also depends on the complexity and difficulty of the procedure and how much experience you have as a centre. And of course, we leave surgical closure therein as an option, particularly if there is a very large defect or there are anatomical features which are adverse to PVL closure. But most of the time, the patient will proceed with percutaneous closure. Horst touched on this, and I think it's important to know when to avoid PVL closure. I think with evidence of active infection, it's an absolute no-no. But although in this patient population, it's sometimes reasonable to think about closure once treatment is completed and enough time has elapsed to know that you have a sterile environment. Again, that's not perfect. Any evidence of valve dehiscence, and look carefully for a rocking motion of the prosthetic valve. And the presence of intracardiac thrombus, again, if you're treating an aortic leak, left atrial appendage clot's not a contraindication, but if you're treating a mitral leak, it is. And left ventricular thrombus is also a contraindication for treatment of aortic leaks, although we've done 1 or 2 cases with a laminar thrombus with embolic protection when there's been no other option. So I think that's relative in terms of where and how you're attempting the procedure. I think if there's evidence of infection, sometimes you just have to wait. This was a 64-year-old man with previous aortic and mitral replacements who had quite a large anterolateral leak, which you see here. He was treated for streptococcal IE and left a good 3 to 4 months post-treatment, but was still symptomatic with heart failure and was brought back and had a very straightforward PVL closure. So I think it is possible. It's just the timing that's important. This was post-treatment. I think it's very important to assess for recurrent infection before you go on and do anything here. Watch for a rocking valve. You can see here, this is a mitral valve, and there's quite a lot of mobility on that valve in a young patient with a reasonably large leak. But I think that's something to sort of avoid at all, because it suggests that the valve is not competent, and then putting devices in here will be a problem. This can be sometimes very easy to spot, sometimes it's more difficult, and it's sometimes fairly progressive. So you see more movement on a valve, sometimes you bring them back for the final procedure. I think it's important to understand the anatomy and take care before intervening on very large leaks. And the problems we've had with paravalvular leak closure is when we've not properly understood the anatomy. This was a patient who had a mitral valve replacement about 20 years before. And you can see on the bottom right, the 3D shows quite a large defect on the medial side. There's also a defect around the lateral side, but actually that defect is an old abscess cavity we weren't aware of, which extends into the coronary sinus, which made actually closure of this defect extremely difficult. We didn't fully appreciate that at the time until we started. And I think it's important to have very careful imaging, and sometimes multimodality imaging before you start. And this is another case in point. again, this is a slightly unusual case, but this was a man with a previous mitral ring, which had partly dehisced, so he had no other significant history, but this was a big hole next to a mitral ring. And I think understanding this case was important because essentially there's ring dehiscence you see here, but just plugging that won't cure the problem, because in plugging that, you'll also pull the ring away from the posterior annulus. And in fact, that's exactly what happened. So we had planned to put a plug in first and then put a valve in ring. And immediately after the plug went in, the MR increased. So it was the right strategy. And that was a fairly straightforward procedure once the plug was in. So I think it's important, as I said, to understand exactly what you're doing. Horst has mentioned fluoroscopic angle planning, and I think use the imaging that you've got. CT can be very helpful for localization, particularly for angles. I mean, you can do that from the echo and the fluoro itself. But if you're planning large leak closure, then I think having a CT sometimes helps define the anatomy a bit more carefully. So I'm just going to stop there. It's a very brief overview, really, of who I think should and who shouldn't be treated. I think that actually appropriate patient selection is probably the most important aspect of PVL closure, and having a clear indication is really important. I think you have to understand the anatomy, and sometimes more than one imaging modality is important. I think that's less so with aortic leaks, which tend to be more straightforward. But using transthoracic, TOE, and sometimes CT to plan things, particularly early in your experience, is a useful thing. And as Horst has mentioned, you need to be confident with multiple approaches. You know, retrograde aortic is a common technique that he uses, but we use the transeptal approach for the transmitral. And I think if you're starting a program, patient selection, start with simple aortic leaks, moving on to more complex mitral is a sensible plan. And I think I'll stop there and take any questions. Thank you.
John, thank you. That was magnificent, as we've come to expect from you. Nice to see you. And,
thanks, Dave.
And I think, you know, we're running behind. We've got a colleague in Osaka waiting, so I think we're going to have to close the session here. I just want to thank Farrell for a superb demonstration. You made difficult things look very simple. And John, thank you for that summary. In his absence, thank you to Professor Severett as well. I think that what we've learned from the session is that paravalvular leak is common. It increases in time, over time after valve replacement. And so in your practice, there are patients like this. Left untreated, paravalvular leak causes a lot of problems with chronic heart failure and hemolysis. And surgery is not the simple solution that you think it may be. The outcomes are not necessarily good. You need multimodality imaging. You need 3D TEE, I would say, mandatorily during the procedure. And you need an experienced structural interventionist. But I think that we've had a wonderful demonstration of a complex technique. So thank you so much to everybody involved. And we'll close the session here. Thank you to all. I also, falls to me, Habib, thank you. As we say thank you to all our panelists as well. Thank you so much for your inputs. Just to welcome our next speaker, we're going to go to Osaka in Japan. And perhaps after we've been watching people do apical punctures and transeptal punctures, it's quite prudent that we have a lecture on how I manage complications in my cath lab. So we're going to cross to Osaka, Japan for Dr. Ishihara. Welcome, Dr. Ishihara, and we look forward to what you're going to tell us. Thank you very much, Habib. I'll hand over to you to chair the next session.
Thank you very much. So we have to close this room now and go into another room in order to get connected to Dr. Ishihara. Thank you so much.
Thank you, everybody.
Thanks for